Good morning and welcome to our webinar today. I'm sure a few people are still joining, but it is 11 o'clock and so we will kick off. My name is Samantha Fay. I am the CEO of Sisu Health and I will be facilitating the webinar for us today. Just before we start, a few housekeeping items. So the session will last approximately 1 hour. Today we will have a number of speakers and then we'll have plenty of time at the end for a question session as well. Everybody will be staying on mute throughout the course of the webinar, apart from our speakers. And I believe that all cameras will be switched off. You are very welcome to add your questions, please do. You will find in the top bar of your Teams screen a little Q&A button. So little sort of speech bubbles with a question mark. Please do select that and include your questions in the Q&A. And we will facilitate and answer those towards the end. We have a jam-packed agenda today, really excited to be joined by 3 speakers who are going to cover a range of different topics, all associated with neighbourhood. I will introduce them more fully later, but we will be hearing from Dr. Leah, who's going to cover topics around neighbourhood and the biopsychosocial model. We'll be hearing from Michelle, who's going to talk to us about the experience in Nottinghamshire, where they've been bringing neighbourhood health to life through a prevention approach, and also from Suzanne from Norfolk, who will be talking to us about their experiences with prevention in their communities. Next slide, please, Jodie. It's very pertinent timing, I think, because many of you will have spotted that a new policy paper was launched yesterday. We've put the link in the chat in case it hasn't been spotted. We've all been busily reading this morning to try to understand what that new sort of context and policy paper tells us about, and I'll just refer to it a little bit this morning. For those of you who attended our last webinar, you will know that we really focused on topics around the implementation of prevention solutions in the workplace. We heard experiences and learnings from several case studies associated with the Department of Health and Social Care CVD workforce pilot, and WorkWell, which is an early intervention health and employment support service, is very much mentioned in this new policy paper as well. But today, this webinar will be focusing more on the community context and particularly on neighbourhood. So neighbourhood health, as per the policy paper yesterday, very much puts the person at the centre of how we deliver their health and care by organising services so they can work together to serve a defined population. The paper states we're trying to create the environment in which local services can work together, be coordinated, funded and delivered in a consistent way that enables what is often described as the left shift to happen in an industrialised way, while still meeting local needs and circumstances. And I think that's a statement we're really going to explore with our speakers in the webinar this morning. We see that the aims of neighbourhood health are very much for the NHS and local authorities to transform how they work together with wider partners. And we're really excited to hear the examples today of how true partnerships are being fostered to benefit all citizens as we look to achieve that left shift from hospital to community and sickness to prevention. The paper also includes goals such as improving people's health and care outcomes, reducing health inequalities, and organising services around the person with more convenient, personalised and joined up care. And it does repeatedly mention several of the topics we're going to focus on today, which are about focusing on prevention, proactive care management, and including using data to effectively manage risk and prevent escalation, as well as strengthening primary and community services and making full use of digital opportunities. The other point that I think it just really does mention, and one that I'm sure we're all aware of, is that integrated neighbourhood teams will be there to help people stay healthier for longer, but that the NHS is not going to define nationally what should constitute an integrated neighbourhood team. And again, I think today we're going to hear about how different locations, regions, and for different population needs, those integrated neighbourhood teams and approaches are going to vary based on different conditions and populations. So I'm just going to talk very quickly as a bit of an introduction to our 3 speakers today about prevention in the broader sense. We know that there's a commitment both to this recent policy paper, but also to the establishment of 250 neighbourhood health hubs. But I like to do the maths, and the maths sort of tells me that 250 hubs for 56 odd million people is only one hub per roughly 240,000 people. So we know that hubs need spokes, and hubs need reach, and hubs need ecosystems within which to work. Our experience is that prevention has to exist as an ecosystem of everyday access points, early identification, behavioural support, digital triage, and clinical escalation when appropriate, all underpinned by real-time data that informs place-based decision-making. Next slide, please. So to set some context of what we see at Sisu Health, I'll talk a little bit more about this later in the webinar, we see really significant proportions of the people who use the in-community self-service platform have not had a recent blood pressure check, which therefore suggests they've also not been in recent contact with significant sort of healthcare. So we know that there is a prevention gap. We know services are available, but we know that engagement remains low for a wide range of different reasons. Next slide, please, Jodie. So I'll just sort of leave with the context today before handing over to our other speakers about that real necessity to design for real world systems constraints and for real people in places where they live. We know we have challenges around the likes of digital exclusion, low health literacy, mistrust, pathway variation. So co-designing with a very local public health and system partnership in mind is really essential. Next slide, please. That leads me on to introduce to you Dr. Leah. Absolutely delighted that you could join us today. Dr. Leah is going to talk about neighbourhoods in a broader sense, really thinking about both that behavioural but biopsychosocial model. Dr. Leah comes from a range of very impressive backgrounds, both in terms of combining frontline NH practice, national policy leadership, and industry expertise. And I'll now pass over to Dr. Leah. Thank you so much for joining us.
Thanks, Sam. Thanks for having me. It's really such a pleasure to be here because this is an area I really care about. Just to give you a little bit of a bit more background on where my interest sits in this area. I'm a liaison psychiatrist, so clinically I've always been trying to think about ways to create care that goes around the person and in particular crosses organisational silos. So that's designing services that go across primary, secondary care, physical health, mental health, and health and social care. And quite often thinking about what the digital enablers are around that, but actually really it's about the services, the clinical face-to-face services, and then also how digital can then be a bit of a Trojan horse, actually, is how I tend to talk about it. And I've done that in a few different spaces, so in industry, frontline in the NHS in a number of different models, and also in some of my national work around various areas. And one of the things that I have been doing is sitting on the National Neighbourhood Digital and Data Steering Group. So I was just going to begin very briefly with a little bit of an introduction to people who might not kind of fully understand where the neighbourhood sites and where that is operating at the moment. Can I have the next slide, please? So what is the neighbourhood programme with the 43 sites? It's a large scale change programme. I'm sure many of you here are already quite familiar with it. It's not proposing to do anything new. This is about integrated care or all the other forms that we've seen. And honestly, this has been the kind of, having spent my whole career in this space, this has been the most positive I've been for quite a long time, because it feels like there's a real coalition of the willing across the whole ecosystem. I think Sam's use of that word is really important. That ecosystem is really important. And I think we're at a crucial time where we can really start making some big changes. And the neighbourhood programme itself recognises that there is hard and soft change. And some of that hard change will be around funding, infrastructure, policy and governance. And then that soft change is about rethinking those delivery models and mindset and cultural shift. And I'm going to come back to that because my talk today is really about that last one, mindset and cultural shift around these models. And of course, there are going to be some things that come under this kind of practical focus area. What do those enablers look like? What does the data and digital capability need to be? What do we need to do with our states? What does our workforce need? And importantly, taking a population level approach. There are obviously target cohorts, people with long-term conditions, rising risk of escalation, people who have multi-morbidity, so multiple diseases and conditions that they're dealing with, and in the main, people with significant psychosocial need. And what all of this means, and in my world, this is all about really shifting to the biopsychosocial model. I'm sorry it's such a difficult thing to say. I did not make it up, but even I trip up over it many times because it's not very easy. But it does kind of, the name is, what it says on the tin, as they say. And it is explicitly articulated as being what underpins Neighbourhood. Neighbourhood is about a shift to the biopsychosocial model. Could I have the next slide, please? So this is where I get a little bit philosophical on you. I won't get too philosophical. It's still a bit too early in the morning, almost into the afternoon now. But in my sort of academic and clinical world, what we often talk about is that in the globalized north, sorry, could go back one. Thank you. Is that what we have in the globalized north is we have a healthcare system that really is predominantly concerned and built around the medical component, the biological component. So that's your acute hospital care, thinking about having your antibiotics that cure your infection, or your surgery where something gets cut out. It's really quite focused on the biology, and that is important. That is definitely important. But what we know is that health experience is not just about this. Health experience for people is actually about biological, psychological, and social domains. And we often blame, philosophically, in my world, we blame Descartes, because Descartes is the person who said, I think, therefore I am, which means you're kind of splitting off this piece around the mind from the body. And we call that the mind-body split. Whereas in holistic terms, biopsychosocial model terms, it's much more about thinking about people as a whole and thinking about them in the full context of their experience. And I tend to quote a Roman playwright called Terence, who said, I am human, nothing human is alien to me. And the reason I use that quote is because it constantly reminds me that whenever I'm seeing somebody in clinic or in the acute hospital, when I'm asked to consult with somebody, it's about really picking up the full context of that person's experience. Could I have the next slide, please? So when we teach this, and to give you an example of how you might think about somebody in terms of this full context of their experience, let's take something like rheumatoid arthritis. So rheumatoid arthritis is an autoimmune condition. And if you think about it in the kind of purely biological sense, sorry, just go back one, thank you. You've got nasty substances, cytotoxic, chemicals and things that are circulating in joints, destroying your joints, and giving rise to these symptoms that can really, really affect people's lives. But actually, if you look at those cytokines that are circulating, those substances that are circulating in joints, in the biological theory of depression and anxiety, we know that those same cytokines are actually implicated in some of the ways that we think depression and anxiety can work. And we know from the epidemiology around rheumatoid arthritis that about 30 to 40% of people presenting in rheumatoid arthritis clinics and rheumatology clinics will have a diagnosable depression or anxiety. Furthermore, we know that when you treat that depression and anxiety, you not only treat the mood disorder, you treat the rheumatoid arthritis itself. You get improvement on the physical components as well, stiffness, pain, swelling. That's literally just the bit in the biological domain. If you then think about this person in terms of their psychology and their social context, the way people experience their disease is really dictated by a whole load of factors. For example, we know that pain itself, the experience of pain, is not directly correlated to the degree of tissue damage that somebody experiences. That's quite a big thing, and it's kind of counterintuitive. We sort of think if you have a big, massive cut or big fracture, that the amount of pain you're going to experience is actually directly related to that. That's a very biological way of thinking about it. we actually know that pain is hugely affected by a number of different things, including, in my world, I see patients with functional neurological disorders. We know that, for example, experiences of childhood sexual abuse really has a massive effect on how you experience pain. And that's because we are not mechanistic beings. We are beings that interpret our world through a number of different ways, and that includes having an effect on how our physical symptoms are experienced and things like pain, etc. We also know that social context matters. There's going to be a very different experience for the person with stiffness in their hands who is a concert pianist compared to somebody who has got different ways of generating income. And we, again, see this in clinic all the time, and it has a tangible effect on how we manage people in terms of their of what they're experiencing. And more than that, it's not just a kind of nice to have, woolly, let's all be, ask people about their lives and not think about it in kind of a really serious way, not take it seriously. We know that when you do this, when you do this biopsychosocial formulation in a proper way, you not only have an impact on health outcomes, both the psychological health outcomes and the physical health outcomes, you also impact system KPIs. This is an economically efficient thing to do. We know that people across pretty much every long-term conditions, we have an evidence base that says when you have this approach, you will reduce relapse rates, which means you're reducing presentation at A&E and you're reducing presentation at GP surgeries. So real impact on system key performance indicators. I once heard someone say that they think that kind of this world, and they was talking specifically about liaison psychiatry, because this is a lot of what we look at, they sort of think it's kind of one of the most underestimated interventions because of this synergistic effect of looking at somebody in the whole. What you can see on the bottom left of the slide is actually what I use when I'm teaching this. So in previous work, we've taught everyone from medical students and nursing students through to professionals who are working in a range of different jobs. We deploy this model across 160 outpatient services at Guy's, King's and St Thomas's under the Imparts programme and King's Health Partners. And that was to rheumatologists, occupational therapists, consultant nurse practitioners of all different types. And I've also done that in various of my models that I've done in other places. And we teach thinking about these biological, psychological and social factors divided up into predisposing, precipitating and perpetuating. And I think this becomes really important when you're trying to think about primary and secondary prevention strategies, because linking this context about, what's important before someone presents with something, what might precipitate a particular presentation, and then what might keep that experience going. It's really important that the way you work with patients and citizens to deal with that takes into account all of those stages in someone's timeline. This is literally a journey for people, and people come at their experience of health at different points, in different ways at different points in their life, and depending on what's going on with them in each of these three spheres. Can I go to the next slide, please? The picture on the left is actually a case study from work that I did right at the beginning of my digital career back in the South London and Maudsley. And we were working with patients with severe mental illness. And it came from a very specific health psychology approach. What we were trying to do is to improve the therapeutic relationship and specifically the power dynamic. So the idea being that, again, what happens a lot in health experience, especially in the globalized north, is that it's medicalized. It's quite transactional. It's a transaction more than a relationship thing, is what it's thought about as. It's not really what it actually is. And it's often the power often sits with the clinician rather than with the patient. And again, we've got a really good evidence base that shows when you work with people in a psychologically minded way that is specifically geared to increase patient agency, which is actually something you can measure through things like the patient activation measure, you will have those improved health outcomes and that impact on system KPIs. So the particular story that I've got here, patient B, who I have permission to share with you, was a 66-year-old gentleman who had bipolar affective disorder. He had been very, very unwell throughout the course of his life. He had been detained under the Mental Health Act, which means he had had his human rights taken away. You can't think of a more coercive relationship than that relationship that people experience when they're under the Mental Health Act. They literally lose their human rights. So none of this, increasing patient agency for him in that experience before. And it was necessitated by how unwell he was. We worked with him during a period of relative wellness for him. And we were also working on patient agency, and we were also trying to tackle that stat that's probably maybe a bit too small on some screens, right at the bottom of the slide, which says that people with severe mental illness lose 20 years of their life compared with the average person in the population. It's a really big number. If this was anything else outside of the stigma of mental illness, this would be a huge scandal. People were dying 20 years earlier than the equivalent person in the population without a severe mental illness. So we started working with him in a really biopsychosocial way with a patient held record. And he was measuring his blood pressure. Nice that there was a blood pressure example right at the top, because this is a group of people which we find difficult to engage in services. We haven't cracked how we get them the right healthcare. And so we were working with him. He had a Wi-Fi enabled blood pressure monitor, and he was tracking his own scores. He was also actually tracking his mood, but he wasn't so interested in that. Where his motivation was actually around his physical health. We'd done some psychoeducation around these physical health parameters, around that 20 years life loss stat. And what happened in his story was that he saw that his blood pressure was high, and he made an appointment with his GP. I'll just remind you again, this is somebody who had been dragged to hospital by the police every other time he's ever engaged with the health service. And he made an appointment by himself, went to his GP, showed the GP his blood pressure scores, which meant that he got treatment for his hypertension. And actually, also, whilst he was there, he felt empowered and confident enough and in control of the situation enough that he showed the GP his mood scores, which showed that they were slightly going high. So he would tend to have manic episodes. And what would normally happen in the past is he would go high, feel so well, come off his mood stabilizing medication, and then become extremely unwell and often crash quite significantly. But because he presented this to the GP early, it meant the GP could do a lithium blood test, which showed that his lithium levels were not actually optimized. And they probably weren't optimized because his blood pressure's high, because he's probably got disease related to hypertension affecting his kidneys, which is affecting the clearance of his lithium medication. So this is what I mean about this biopsychosocial approach. These things that people experience, they're connected. It's not one thing. And when we're thinking about how we can help people live their best life, we have to really be thinking about that in the round and guiding our systems and building, I think, particularly our digital systems to be able to really tackle that complexity and help us get a hold on that. So this is why I really advocate in any of the services, products at a national level or an industry or frontline to be really underpinned by having a digital clinical services approach, I'll come on to very briefly in a moment, and having these guiding principles, many of which you've already heard me talk about a little bit now. Biopsychosocial model, something called the logic of care, thinking about health inequalities, that 20 years life loss stat, and really gearing this around the evidence base around behaviour change and supported self-management. Can I have the next slide, please? Very briefly, before I wrap up, the digital clinical services approach just says that we need to treat our digital services like we do setting up our clinical services. We sometimes tend to think about them as technology and an add-on, whereas actually you have to think about these services exactly the way you do clinical ones. It's a channel like anything else. And being able to design for all those factors included in that service wrapper, combined with those principles that I just talked about on the previous slide, is really important to achieving the best outcomes for people. I think that's the end of my slides. Can I have the next one? Yeah, I've just got a couple of definitions, but actually I think what I'll do is save those for the Q&A, unless anybody particularly wants me to go into them a bit more. But the thing I really want to leave you with is that quote from Terence: "I am human and everything that is human is important to me." When you are thinking about how you can best deliver neighbourhood models, it's bearing in mind that it's important to kind of pull that context in and use the evidence base that comes from biopsychosocial model literature, etc., and use that to really gear where your services. And that's, for me, that is the way we're going to have the most impact on improving people's lives. Thank you very much.
Thank you so much, and I'm sure we'll come back to some questions later. Just a reminder, please do put your questions in the Q&A, which is available at the top of your screens. Thank you so much, Leah. We're now going to move on to hear about how some of those principles are being implemented in real life. We're going to come first to Michelle. Michelle is a transformation manager in Nottingham and Nottinghamshire ICB, where there's been a range of different prevention programs that have been implemented very successfully, but still quite early, and lots of sort of learnings and testing and so on to be experienced as well. So next slide, please, and over to Michelle.
Thank you very much for having me here today. And I'm really pleased to be joined as well by lots of people from Nottingham that are on this webinar. So thank you very much for your support today. So if I can just go to the next slide, please. The way in which we've worked across Nottingham City is in conjunction with the Nottingham City Place-Based Partnership. We have, in November 2024, worked with lots of our sister partners at an event, bringing everybody together to really have a focus on a priority of our population and that prevention work stream. And cardiovascular disease and hypertension is one of the leading risk factors in Nottingham City. So our current hypertension detection rate at that time was 28.72%, which is actually slightly under the national average of 29%. So we actually came together and said, right, we want to work together, we want to have this focus, we want to get into our communities, but how can we do this collectively? And what we've been able to do, if I can go to the next slide, please, we've been able to then focus on a programme which we've called the Long-Term Conditions Integrated Neighbourhood Working Programme, which has different projects within that focused on pre-prevention, prevention and secondary prevention and intervention. And we've pulled together different projects, one of which was working with the majority Black-led churches to really understand within the communities why African and African Caribbean men were not coming forward to have a blood pressure check, for example, or why men in general were not coming forward. And what we've been able to find from that particular project and different projects that we've led is that there's a lot of barriers to trusting the NHS, trusting health services, non-English speaking populations struggling with those language barriers. And so we've been able to then look at that, as well as lead a project which was in September. So if I could go to the next slide, please. And in September, we led the Know Your Numbers campaign. The Know Your Numbers campaign did have some real positive response, and people did go and get a blood pressure check. But what we found was, as we were encouraging people to go into community pharmacy, that actually community pharmacies close at 1 o'clock. So the population of those that are working were unable to take action during the week, but actually at weekend found there was those barriers from 1 o'clock because there was nowhere really for them to go. So we were really fortunate to then look at this as a challenge and see, well, what can we do? Where are people going? How can we get those working people to have a blood pressure check? And actually, where can we have something available that's close to them, that's actually somewhere they can go where a store or environment doesn't close at 1 o'clock on a Saturday? And so we were able to deploy the 2 CSU health stations across Nottingham City, one being in Boots, Victoria Centre, and one being at 2 community areas, so Stapleford Health Centre and more recently Bramcote Leisure Centre. And these stations then are available for people to walk into all hours, later on in the evenings and at weekends, to have that blood pressure check. If I can go to the next slide, please. So the initiative has been developed through strong collaboration across the system. So we've got strategic oversight from the Nottingham and Nottinghamshire Integrated Care Board, support from our Nottingham City Place-Based Partnership. The project specifically with the CSU health stations has been supported by Health Innovation East Midlands, and we've got the 2 CSU health stations, and we've really partnered well with Boots Store in Victoria Centre, Nottingham. And then what we've encouraged is for community services of our integrated wellbeing service, Thriving Nottingham, and our alcohol and drug support service, Change, Grow, Live, to actually have the opportunity to be involved by being referred into those services. So when an individual goes and has a mini health check, what they can then do is, through the lifestyle questions, answer those questions and then have the opportunity to be referred through to Thriving Nottingham and Change, Grow, Live. If I can have the next slide, please. So the CSU Health Station in Boots, specifically in the Boots store, was situated in that store on the 9th of December 2025. And from the 9th up till the 9th of March 2026, the station had delivered 1,701 checks. From that 1,701 checks, 600 of those individuals were over the age of 40. 60.7% of those over the age of 40 had reported that they had not had a blood pressure check in the last 12 months. And so what we've seen is lots of engagement with and strong engagement from individuals using that station, and specifically because Nottingham City is very closely surrounded by areas of higher deprivation, we have had a lot of users from those IMD quintiles 1, 2 and 3. Next slide, please. So the way in which we're looking at the economic impact and identifying, well, actually, has the station had those benefits that we want to see across the system? We are working and using the modelling from the UCL partners size of the prize analysis. So we've identified that for an individual that would go on to have a heart attack and stroke, the cost of that is £88,830. If an individual uses the station, it is free for them to use. It is 4 minutes of their time, and actually then they can have that support with a local pharmacist that is in store to get advice if the blood pressure is identified to be high. What we've also been able to do, and through the continued analysis, is see and look at how that £88,840 is saving that system in Nottingham City and preventing an emergency admission and long-term stay. So we've really already started to see those benefits early on from the station only being in place for a short months. The station at Stapleford, again, it was in a health hub. It was surrounded by a lot of older people that were classed as frail. And our frailty score in Nottingham City, the age of frailty is 55 plus. So we've been able to really identify, again, a lot of high blood pressure checks in that area. And I'm hopeful, since the station has been situated in Bramcote Leisure Centre, that we'll start to see that as well. It's been placed at Bramcote this week. Next slide, please. Thank you.
Lovely. Thank you so much, Michelle. Just a reminder, please do include your questions and we'll come back to all of the speakers at the end. So from an example of projects in Nottingham City now, over to Suzanne, who's going to talk to us about a slightly different, more rural context. So Suzanne is an advanced public health practitioner from Norfolk County Council. Some similar but also some different challenges in terms of the demographic and also the reality of your geography as well. So over to you.
Brilliant. Thank you very much. And thank you for the introductions and for having me here today. So yeah, my name's Suzanne. I'm an advanced public health practitioner at Norfolk County Council Public Health. And I lead on our NHS Health Checks programme. And I've been doing that now for the last 4 years. And I'll be able to just talk a little bit about kind of where we're at really with our NHS Health Checks in Norfolk. So next slide, please. Thank you. So firstly, I think just setting the scene a little bit in terms of what sort of Norfolk is and sort of demographics and the rurality of Norfolk as a county. So we are quite a large county, quite rural as well. And one of the sort of significant things that we've got regarding our county is that we've got an ever aging population. So we do have quite large pockets where there is a rise in the aging sort of population. In Norfolk and Waveney, unfortunately, to focus on kind of things like the causes of death for males and females, dementia is a leading cause of death, and then following that, heart disease, stroke, and also lung cancer. So just looking at kind of a recent Norfolk and Waveney population overview, we also know that a significant amount of our population live in the 20% most deprived areas in England. And in terms of the sort of the locations that we have in Norfolk, some of our city and also our towns are largely sort of centred around those kind of areas of deprivation. So Kings Lynn in West Norfolk, Norwich, Central Norfolk, and also Great Yarmouth in the east. And unfortunately, when we kind of look at those more deprived areas compared to those affluent areas in Norfolk, there's quite a stark difference in terms of the years lived, equality years, but also the length of those years as well. So men living in the most deprived areas in Norfolk live on average 9.1 years shorter than men living in the most affluent areas, and for women that's 7.1. So that's quite a significant difference, unfortunately. And looking at cardiovascular disease, that's the second leading cause of premature death in Norfolk. And obviously that's very important to recognise in terms of what we're trying to achieve with our NHS Health Check programme. So kind of reviewing those sort of stats around the areas of deprivation, but also those kind of those core 20 plus groups, inclusion health groups. A recent kind of review of that data in Norfolk highlighted those opportunities to be able to, understand some of those perhaps riskier sort of behaviours and things that come out in those groups. For example, smoking rates tend to be higher in those groups, heart disease, hypertension, and also mental ill health are more prevalent in those groups. Next slide, please. Thank you. So just in terms of, again, a little bit more sort of context around Norfolk. So in 2022, which was when I joined, we had completed a strategic review around our NHS Health Check programme. And based on the kind of the findings of that strategy review, we set some ambitions that we wanted to achieve, milestones that we wanted to achieve within a 5-year sort of period. So we're in year 4 of that now, and with our NHS Health Check sort of focus, we wanted to see more invitations going out, improved overall delivery and uptake of NHS Health Checks, but also importantly, really focusing on those areas of deprivation and having NHS Health Checks reach those people living in IMDs 1 and 2. And we put quite a lot of different things in place to be able to do that. We commissioned a community-led NHS Health Check provider. We also really created a strong workforce in terms of upskilling and training our practitioners for NHS Health Checks and bringing them together to be able to share good practice and really kind of emphasise what it is that we're trying to achieve with NHS Health Checks and really looking at that prevention at its core. And I'm really sort of proud to say that we have been recognised from the Local Government Association. We had a case study completed on our progress that we've achieved over the last sort of 4 years. But as much as what we have achieved, we don't kind of rest on our laurels on that. We are always looking at kind of ways that we can create flexible opportunities for people to access health checks. We know that there are still pockets across Norfolk where uptakes is not where we want them to be, and unfortunately that does correlate more to those areas of deprivation where we know those health inequalities are really embedded. So we definitely were looking at that time to create some different opportunities for people to access health checks. And that's where we kind of went towards using our CSU machines. So back in February 2025, we commissioned 2 health stations as part of a year-long pilot to be able to complement the NHS Health Check Programme improvement programme that we were running, and to really hone in on those flexible opportunities for getting people exposed to that preventative healthcare. So we looked at our local intelligence and our data, which is obviously a core thing that we do in kind of public health. We want to be evidence-led. So we utilised hospital admissions data for heart attacks and coronary heart disease. And more importantly as well, we really looked at those kind of deprivation indicators, and also our uptake of NHS health checks across areas of Norfolk as well. And from that, we identified 2 key areas that we wanted to look to place the health stations. And one of those was in Kings Lynn and the other in Great Yarmouth. So as previously mentioned, 2 areas of quite high deprivation. And so we worked with our local partners and again teams within sort of public health to really identify some settings that were able to kind of really try and help with that access to the health stations. So we really wanted to try and find settings that provided that maximum access, so real convenience, high footfall in particular, and also held an ethos of community engagement. And that's where we kind of led to identify 2 supermarkets within those 2 areas, one of them being Tesco in Kings Lynn and the other an Asda in Great Yarmouth. So we were thinking about having stores that had like a 24-hour access, for example, and also good access in terms of transportation routes, like being on bus routes, for example. So I was able to engage with the community connectors there, the community champions at both stores. I did come armed with lots of prevention stats and reasons why health stations would be a great asset to the store in the local community that it's serving. And I was actually quite lucky to be able to be welcomed, and it was quite a smooth process to be able to set all of that up, which is very fortunate. What we also, when we had those stations in place, we were able to bespoke some of the user journey. So when someone was actually having a health check digitally, they were able to be signposted to our local Ready to Change website. So that is a digital platform that has its foundations in behaviour change. So exposing people to the guidance, information, support, and helping them, as it says on the tin, to assess their readiness to make a change. And ultimately as well, it's our gateway to a lot of our commission services that we have in Norfolk, to be able to support people when risks are identified in their journey. Next slide, please. Thank you. So I'll just, I won't go into too much detail about the outcomes that we've had from the health stations, but there are quite some notable and interesting statistics that we've got around the health stations for Norfolk. So from that year period, so looking at the middle of February to the beginning of March, just over 7,500 health checks were completed, and just over 6,000 of them are unique users, so have used the health station once. 12% are repeat users. On average, 20 health checks a day. And quite interestingly as well, the stations have been used by younger adults across both health stations. And quite an interesting one as well in terms of the split between females and males in terms of the usage. It's around 50% split, and that's quite an achievement in terms of when we reflect on some of the usage for our other commission services. For example, there is generally a higher usage of females compared to males. So actually, the health stations have been able to engage more males. One of the things, obviously, that we set out from the get-go was to try and engage people from very deprived areas, and the health stations have been able to achieve that with the of those that are using the health stations, the largest proportion is coming from IMD's decile 1. Also, in terms of the actual timings of the use of the health stations as well, very interestingly, most of the use is in the afternoon and also the evening, which again I think relates back to that kind of accessibility. Typically in healthcare, it can be sort of 9 to 5 sort of hours. So really great that we've been able to see that flexibility actually and enable people to access a health check outside of those typical hours. Thank you. Next slide. And again, just some of the sort of the risk profiles that we've been able to identify. So I guess unsurprisingly, but obviously not a very nice statistic, in that a high proportion of the users were current smokers, and that does align to the data that we have in terms of higher rates of smoking in those areas of deprivation. But when we were able to identify that very early on, particularly when we started off in the Tesco Kings Lynn store, it was quite apparent that a lot of the staff were using it very early on in that kind of honeymoon period. And we were able to just emphasize that support locally that we had with stop smoking services. And that was kind of promoted within the store quite heavily. So really able to kind of react quite quickly to that. And then we've got some other statistics there in terms of quite a high proportion of people being identified as overweight and obese, and that comparison to kind of the prevalence that we have across Norfolk as a whole. But in terms of those repeat users as well, we're seeing that some people are now actually changing their lifestyle. So 17% of people that have come back to use the station have actually become non-smokers now, and we can see there a bit of an average weight loss of people coming back and monitoring their weight, as well as 3% people reducing their blood pressure down to a normal range. And interestingly, we do see a kind of a variation in terms of those repeat users. And I think you start to get some insights in terms of people's sort of priorities and values in terms of what they want to get from the health station. For example, some people might just go to monitor their blood pressure. Other people just are interested in monitoring their weight. So there's some good sort of insights there. And we've just got a bit of anecdotal feedback there from people as well about that convenience of the health station being placed in the supermarket. Thank you. Next slide. Thank you. And just a little bit of a summary now of some of our learning. So we really do feel that supermarket model has worked well to engage younger adults, men, ethnic minority groups as well, and people living in those deprived areas. And one of the things that I would definitely emphasize with the location of the setting is having it absolutely visible. We did learn quite early on a position in the store that we thought was actually quite ideal, but it really didn't work. And so we had to react quickly to bring it more into sort of front and center. And even though we had a couple of concerns around that kind of confidentiality, I think that the stats prove otherwise in terms of people are actually very happy to have their health check. And so that visibility is really important. So kind of our next steps really. So we really do want to expand those health stations across Norfolk, and really looking at where that need is highest, and looking at more of a flexi model as well in terms of being able to bring it hyper local into those neighbourhoods and into those communities that are really going to kind of benefit from it. looking at those developments for signposting opportunities. We relied more heavily on QR codes for our signposting, but I think a next step to be able to really try to hone in those signposting opportunities and helping people to bridge that gap from being exposed to perhaps a risk that has been identified and taking that step into support services. And then exploring opportunities to work with our local services to really support people with digital literacy, and using the stations perhaps as a bit of a kind of a way of being able to develop that confidence in using digital healthcare. And we do have some teams in Norfolk that really do support people with that kind of digital sort of literacy. So I think that the health stations are definitely going to have a role in that. We're very much looking at a kind of a multidisciplinary approach to identifying those areas of high need and where it will bring most advantage by working with our health and wellbeing partnerships, and also creating lots of opportunities for public voice in terms of helping them to feed into, you know, what they want from that sort of digital experience and what would be most valuable to them. And then finally, of course, really sort of bolstering our NHS Health Check programme, but also potentially future NHS Health Check online, as well as another kind of point to be able to help people to have those health checks and monitor their health going forwards. I'll stop there because I think I'm over time. Apologies on that one, but I'm happy to sort of take questions and expand more on that. Thank you.
Thank you so much. I mean, I think we've covered so much ground in the 45 minutes so far, from biopsychosocial to urban to rural to hard to reach communities, whether that be males, excluded communities, to using supermarkets, pharmacies and so on. We've covered so much ground, so thank you. I'm just going to wrap up. I promise I will take 2 minutes to do that because I know we want to get to some Q&A. Just a bit of a warning to speakers, please have a look in the meeting chat. We've got lots of questions, and lots of questions in particular about pathways, data flow, sort of relationship and balance with the NHS Health Check and so on. So probably particularly for Michelle and Suzanne, just to give you a bit of warning, I'll come to you shortly to perhaps give us some comments around that as well. Jodie, I'm going to go really super fast. So next slide, please. And next slide, please. Just to wrap up, we've talked across a lot of different topics. It's obviously a huge area to cover. Just to sort of summarise really some of the things that we've touched on very much around sort of the behavioural science and the pathways to impact. So we really see that the starting point in many of these cases to reach these particular communities and some of these hard to reach cohorts is the opportunity. Making access super visible, easy, available in everyday settings and at really convenient times and locations for people. That then enables engagement and capability as people use the service, build awareness, build understanding, and that in turn supports motivation and action, leading to lifestyle change, engaging with local services, and over time, system level and improved sort of health outcomes, reduced inequalities and reduced pressures on services. Just to bring it to life for people, next slide, please, Jodie, just really quickly. You've heard some mention of the use of the Sisu Health platform. I think that top left is, I think it's Tesco, Suzanne. You would know better than I do. We've had, for example, Cambridgeshire, and we've been working with the mosques to really sort of attract some of those populations. More recently at the football, as recently as Sunday with Nottingham Forest, health check buses, and the occasional special visitor such as Father Christmas or Percy the Pig as well, just to sort of highlight it really is accessible for all. Next slide, please. I won't talk any more about this. I think we've really made some connections about some of those locations and how those locations enable us to get to some of those populations who may not be engaging with more traditional models around health checks. Next slide, please. Suzanne and Michelle both touched on this, but really we need that evidence of impact. So we are seeing significant numbers of people tell us that they're making healthier choices post their health check experience. Those who need to are engaging with a healthcare professional, and we are seeing significant health risk improvements as well, with numbers such as 20% of people who are coming back to the health station reducing their blood pressure risk. Next slide, please. One of the areas that everybody talked about was really that sort of learning circle. So using data on almost a real-time basis to understand, are we hitting the right audiences? Are we getting drop off? are we optimized in terms of who we're reaching, how we're reaching them, and the impact that we're having? So the real-time sort of data flow is super important so that we can co-create and really work in partnership to improve and optimize as we go. Next slide, please. Just to summarize, really, I think these were the learnings I took away from some of the presentations today, but I'm sure the audience will have many more. We'd love to hear audience feedback as well on any other topics that you'd like to cover. And also, if anybody in the audience would like to share their case studies at future webinars, that would be really welcome too. But now to the Q&A. If we just go to the next slide, Jade, just to give us a bit of context. So, as I said, lots of questions around data and relationship with the NHS health check. Suzanne, you talked quite a lot about some of this had come from your review of the NHS health check. Could you just quickly cover off how the relationship between the in-community, what some might call mini health check, is seen in relationship to the full sort of NHS health check?
Yeah, so what we were able to do with the use of our health stations is that we were able to kind of ask an additional question within the user journey to identify at their sort of face value whether they had had an NHS health check in the past. And so being able to kind of gather that data gives us that further insight in terms of people, you know, who is accessing the mini health check at the health station and who is potentially is or isn't accessing the NHS health check programme as a whole. And so that insight enables us to take that data back to our key providers, our GP practices in particular, and help them to kind of, again, I think really see the emphasis on those opportunities to be able to get people a health check. And I think we have to be sort of pragmatic about things, is that we know that not everybody is going to take up an NHS health check. So with having this additional sort of mini health check means that for whatever reasons why that person might not take up a full health check, NHS health check, having the health station enables them to kind of fill a little bit of a gap there and get them exposed to that sort of preventative health care, get their BP checked, and then just use it as a bit of a platform as well to be able to almost like set that seed to perhaps going into an NHS health check, or at least going into primary care if that risk has been identified, to be able to get them the sort of the care that they need with the risk identified.
Thank you. And I don't know, Michelle, if I could come to you, perhaps you could share more about how that pathway transfer into, it's thriving, isn't it? It's happening in the Nottingham area, so that people are sort of having both their data and being moved into local health and wellness services.
Yes, so following them having the blood pressure check and height, weight, BMI, they're then asked questions around their exercise and physical activity over the week, and also their alcohol use and smoking if they're a smoker. They have the opportunity at that stage to then request to be contacted by Thriving Nottingham, and so that then formal referral will go across to Thriving Nottingham, and they will pick that up and provide the information to the individual and ask them if they'd like to join one of their classes. And programs. The blood pressure check is also, the result of that is also sent across to Thriving Nottingham as well, so that they can understand if that blood pressure was high, because that will encourage Thriving to provide more of a tailored approach and support program to that individual.
Thank you, Michelle. And I think we haven't covered them today, but we covered in our last webinar a case study where the data is transferred to GPs post a fully digital version of the NHS health check, and that does incorporate blood test pathology as well. I know we had a couple of questions on that in the chat. So in the Solihull Council example, we are both transferring full data to the GP as well as incorporating blood test pathology in that data too, and happy to take any questions outside of the webinar on that. We're really short on time, so Leo, I was going to come to you to perhaps just sort of close this out, if you could, with I guess a pretty general question, which is, I know you've come into this session with a passion for sort of ecosystem and digital and really driving impact. So where do you, with all your sort of relationships and interactions with the sort of neighbourhood strategy, where do you see digital playing the biggest role in enabling sort of neighbourhood health and neighbourhood strategy? So just a small question to sort of finish us off for the day.
In how many seconds? So I think it's a really, really important question, and hearing just literally the answers to the questions just now actually kind of articulate what I want to say, which is I think the community, the suppliers, the commissioners, the practitioners, this community is really crucial to being able to surface up what that ecosystem needs to look like. So I'm design trained as well, and one of my sort of big things about all the stuff I've been saying about biopsychosocial is that we will not get benefit until people will not get benefit from improved health outcomes until we think of that ecosystem and do the end-to-end service design. We have a real problem, I would say, of doing little pieces that sit in certain scopes. So Suzanne was just talking about driving people into certain places when they've had their blood pressure checked. And we've got to be thinking about, as an ecosystem, how we drive that end-to-end service design, because we are dependent on those relationships. And that, for me, is where digital has the biggest role to play. Being able to track the data, being able to make sure those interactions are happening so that we are optimizing that behavior change of driving people to the right outcome. And I think it's quite exciting, actually. I think, looking at the questions, I was looking at various of the questions, and I think Funmi had one in particular that I think captures that detail of this is the sort of thing we are all dealing with, the same problems wherever we are in the country. And then when you've got pieces of national infrastructure like health checks online, etc., that's all got to be considered part of the same system. And so my kind of call to action would be to all of you who are working on the front line of this is to surface that. You've got to surface that because it's really important. That's not going to come from a central place. You need to surface what that service design end-to-end needs to look like in order to actually be able to serve citizens.
Thank you. I think that's a great space to end. Exactly bang on time as well. Just to reiterate my thanks to all of our speakers today, but also to all those behind the scenes who've helped us organise this webinar. Really, really appreciated. We'd love to hear from you, the attendees. Thank you so much for attending as well and spending the hour with us. We will take offline the questions we haven't been able to answer today, and we'd love to hear your feedback and thoughts on what would be helpful for you in your roles in terms of future webinars, and if you have case studies that you would also like to share with the wider audience too. Thank you all and enjoy the rest of your day. Take care.